Good afternoon and welcome to this week's Independent Sage briefing. More areas in the UK are going into local lockdown, social restrictions are being tightened, and now the most powerful man in the world has tested positive for COVID. So as ever, there's a lot to get through today, but we're going to start with an update on this week's figures, and after that we'll go straight to questions from our special guests, press and members of the public. So to get us started then, here is Professor Christina Pargle with the latest figures. Christina, over to you.
Okay, let me just share my screen. Right, so I'm actually thought I would take this opportunity to take stock on September and not just the last week, because it's been quite an eventful month. So I thought it might be worth just kind of trying to dig into the data a little bit more and understand kind of where we are now that we're starting October. The long and short of it is there are both good and bad signs. And I'll be going through kind of confirmed cases, hospital admissions and deaths, and then thinking a bit, well, how do we understand the picture that that's giving us? You know, where is it happening? Who is it happening to? And kind of what are the mechanisms? Like, how is it happening? And then really thinking about test and trace. And I haven't talked about it for a little bit, but I'm going to talk about it more today because that is our way out of current restrictions and kind of saying, well, how close are we? What do we need to do to improve? And then just kind of summarize, and it's nicely coded summary so you can tell what the good and the bad news is this week. So this is the number of new UK confirmed cases. So people who've had a positive test, that has carried on going up pretty steeply. We were just over 7,000 this week we hit, but there are still problems with getting tested, and there are going to be a lot more cases in this. So this on its own doesn't really tell you that much. We can look at where they're happening. So this is by nation, and you can see that Scotland and England have the most number of confirmed cases per population, followed by Wales and then Northern Ireland. But you can see that since kind of a quieter August, all the nations have seen quite steep increases over September. If we dig a bit further into England, again, you see there's a lot of difference. So by far the most number of cases per population are in the Northwest, Northeast and Yorkshire and Humber, followed by the Midlands and then London. We'll be looking at this a bit later because, again, this is confirmed cases and seeing whether this could be, whether there's any impact of who's getting tested on this kind of overview. When you get more cases, you will get more hospital admissions, and we have seen that in September. So from, again, a reasonably quiet August, from the beginning of September onwards, they've really increased. Now, the last week has seen that kind of level off. And what I wanted to do to look at that is say, well, actually, you know, does it change by region? And I think that's where we're now seeing there are kind of almost two epidemics at least going on in the UK. So in the north, and then the rest at the north of England, and then the rest of the country. This is English data because we kind of need reasonable numbers of admissions to look at trends, and England has just a bigger population, so it's easier to do. So this is looking at the different regions, the 3-day moving average of daily admissions across the regions, and you can see that it is still very much driven by the Northeast and Northwest, and they're still kind of going up over the last few days, whereas in the rest of the country, there were increases that are now kind of stabilizing. So it looks as if the hospital admissions are still going up in the north, and it looks like they're steadying off in the rest of England. Again, what we're seeing now is that once you've had a lot more hospital admissions, a few weeks later, it does then get followed by more people dying. So this is Office of National Statistics registry data. So this doesn't matter where someone died. If they have COVID on their death certificate, then it counts as a COVID death. And that's probably the gold standard of how you count. And for the last 2 weeks up to the 18th of September, it has increased by, it's almost doubled since the 4th of September to the 18th of September. So this, I mean, we're nowhere near where we were in the spring. So that's a good thing. But it is the first time really that this has increased since April. We can also look at daily deaths. Now, I don't think 28 days of a positive COVID test is a particularly good measure, but it is something where you have a daily number that goes up to now. So although I don't want to think too much about what the numbers are, but you look at the trend and you can see that trend is increasing. So I think we would expect next week the ONS death numbers to go up again. And I think as long as admissions stay at their current level, you will see deaths follow, unfortunately. So think about who are the cases, and this is where the Imperial REACT study, which I talked about a few weeks ago, which tests 150,000 people every month in England. And these are people who are randomly selected, so it doesn't depend on availability of tests, or it doesn't depend on you having symptoms. So this is a really, really good measure of where COVID is in the country. And because of the importance of where we are right now, they released interim results yesterday after testing 84,000 people from the 18th to the 26th of September. And their previous round of testing was 20th of August, 8th of September. And that's when they first said, oh, hang on, look, we're really, really increasing really fast now. And this is looking at the change since round 4 at the end of August and round 5, which they're still ongoing, but this is up to 26th of September. And you can see that's the difference between these kind of medium blue bars and the really dark blue bars. And you can just see here just quite how much more COVID there is now at the end of September than there was at the end of August. So we are in a situation where it's circulating much more freely. You can see again that it's in the 18 to 24-year-olds at the highest prevalence, almost 1 in 100. They estimate of 18 to 24-year-olds currently have COVID, which obviously has implications for universities, followed by the 25 to 34-year-olds. It's still least prevalent in people over 65, and that's really good news. But what isn't good news is that it's increased massively from here, from a really small percentage at the end of August to a much higher percentage relatively at the end of September. And if that continues, it will result in more hospitalizations. So that's something really to keep an eye on. The other thing that I thought was interesting about this data is looking at school-aged children down here, and they do not show more infection than the rest of the country. And to me, I mean, other age groups, and to me, that means that schools aren't driving transmission, at least not at the moment. You're not seeing disproportionately more school children testing positive. And remember, because REACT tests people randomly, it does not depend on them having symptoms. So it's not a question of children being more asymptomatic or anything. So I think that is good news in terms of schools. The ONS infection survey was released today. That also saw the same thing, 17 to 24-year-olds. Imperial estimate is that overall in England, 1 in 200 people are infected. The ONS estimate is quite a bit lower than that, but the REACT study is like 3 times the size at the moment, so I'm kind of more inclined to go with that just because it's higher numbers. The other worrying thing that the REACT study showed is that people from a minority background are twice as likely to be infected with COVID. And we already know from the first wave that people from minority groups are more likely to be severely ill, and we're seeing that right now. So the National Intensive Care Audit released its report last week, and it showed that people in intensive care are disproportionately likely to be from minority background. So I think this is one of those things where when COVID spread, it is going to impact the disadvantaged and more vulnerable groups in our society most. So that's another reason why we really do have to try and get transmission down. This is where the REACT study found the cases. So again, you see the Northwest, the Northeast, Yorkshire and Humber are the highest groups, but they're also closely followed here by London. And London has a higher prevalence, so more people in London have it proportionally than in the East or West Midlands. And the reason I'm pointing that out is because if you just look at confirmed cases, this is the plot I showed earlier, the Midlands looks like it has more cases per head than London. And this makes me wonder whether there's a testing effect here, whether fewer people in London are getting tested, either because they choose not to or because they can't access tests. And so I think this is where you do have to be a bit careful about using just confirmed cases. And this is where the REACT study is so important, because it's kind of showing you where the infection is without that kind of bias. The symptom tracker app from King's College London, they announced this week that they're now finally seeing a slowdown in growth. That's a really good thing. You can see here their estimated number of new cases, and it just shot up in September, but the last week has just seen it level off. So they now estimate R is about 1.2 across the UK. The REACT study estimated it was about 1.1 in England. So it's definitely coming down, and that's a really good thing. But there has been this fourfold increase over September. So we just have a lot more COVID now than we did before. Office of National Statistics also suggests there are signs that it's leveling off. So it looks like we've probably now got a doubling time of 3 to 5 weeks. So we have bought ourselves a lot more time than where we were 2 weeks ago. And that is unequivocally a good thing. So what could be driving that? Like, why have we managed to slow it down? And this is where I was looking at this. This is the Office of National Statistics. There's a weekly opinion and lifestyle survey of adults. And this is their data for the percentage of people who said they'd left home to either meet up with people in a public place, that's this blue line, meet up with people in a personal place, so go around to someone's house, that's the black line, or to go out to eat and drink in a restaurant, pub or cafe, and that's the red line. And you can see that since the end of August, all 3 of those things have come down, and they're continuing to come down. So people are going out less and they're socializing less. Now, whether that's because of restrictions or because they're worried about COVID, I don't know, but it does seem to show that our behavior is changing, and likely transmission is changing because of that. And just note that this data is from before the latest restrictions were implemented on the 22nd of September. The survey also found that people are saying they're doing a lot of social distancing, and older age groups particularly likely to say they're doing social distancing. 97% said they wore face covering at least once in the previous week. Over 90% say they'll wash their hands as soon as they come home. And there's been a slight increase in people working at home, but only by 4%. So I think that's something where we could still really impact transmission, is encouraging more people to work at home if possible. And then just this other survey, Opinion did a survey on the 23rd of September, so just after the latest restrictions had come in. And they asked people if they were more or less likely to go to pubs or restaurants over the next few months, so from now onwards. And almost half of people across all age groups said they were less likely to go. And that was true in all regions, all demographics. And so I think this could also help us slow that people are worried. 76% of people say they're worried about COVID. Only 16% of people thought the new restrictions were too strict. So I think people are responding to the situation and are changing their behavior to help slow down the growth. So that's kind of where we are. So I just want to think about where we need to get to. So this is kind of looking at test and trace. So the first thing I wanted to do was look at number of tests processed per day in the UK, because we know that since the beginning of September, this has been an issue. And what you can see, this is from 10th of August, is that in the first week or 2 of September, there was an increase, particularly in community tests, up to about 100, just over 150,000 a day. But since the middle of September, this has stayed absolutely flat. And that is worrying, because infections are increasing, and so you'd expect there to be higher demand for tests, but we're not seeing an increase in tests happening. Last week, I kind of showed that it looked as if they were prioritising care homes over other types of community tests, because care home tests fit into this bracket. And this week, I wanted to look at how they are kind of coping with hotspots, because that was quite interesting to me. So, but first, there is some good news in the latest test and trace report. So the times to get test results have come down. So results are now getting out quicker. That's good. And also the distance people have to travel to get a test has gone down. So that suggests that people are finding it a little bit easier now to get a test, and they're processing them a little bit quicker. So that is definitely good news, even though I am worried that this capacity is not going up. So this is looking at the number of tests processed per week per 100,000 people so that you can compare things. And this is looking at 7 different local authorities. So Bolton, Rossendale and Bury in the northwest, and then Barking and Dagenham, Havering, Waltham Forest and Hounslow in London. And on the 31st of July, Bolton, Rossendale and Bury were added to the Public Health England watch list. And what you can see from then is that tests processed there went up quite significantly over August, whereas tests in London didn't. And then at the end of August, they were all had their severity increased, so they were considered more at risk. Again, tests there in September. So this is once we know that test capacity was constrained, went up. So it looks like they were prioritizing tests for the areas on the watch list, whereas the tests numbers in London did not go up by much at all. As of last Friday, all of these 4 London local authorities have been added to the watch list. And so what I'm wondering is whether, had there been sufficient tests in London, they actually would have been added earlier, because we saw from the REACT study, London actually has a higher rate of infection than you would get just from looking at confirmed cases. So I think this is one of those things where it's really good that hotspots are having, or the places on the watch list are having lots of tests, but it worries me that if you're not on that watch list, you're not being spotted early enough. And just contact tracing. So these are all the metrics that you get from NHS England. Well, some of them. They've been pretty flat over August, except there's this one big change, and it's a really important one. This blue line is the percentage of new cases, so new confirmed cases referred to contact tracing who were then reached and asked for their contacts. And that's gone down over the last 2 weeks from about 82% to 71%. That's quite a big drop. And it's really concerning because that's the first step of actually finding contacts and isolating them. And we desperately need contacts and cases to self-isolate. So from this week, you can now get £500 if you're a contact or a case. And I hope that will help and support people, but I don't think it's anywhere near enough to help people self-isolate. But what's really concerning is that NHS Test and Trace released maps of the kind of these metrics. And this is the map of percentage of cases reached. So darker is better. And what you can see is that in the northwest, it's a bit lighter. So you have fewer cases are being reached in the northwest of England. And if you look at contacts reached, that's even worse. So it's much, much lighter in this northwest region. So far fewer contacts are being reached in the northwest as well. So what you're seeing is that in the area that has the highest level of infections and the highest rate of growth, contact tracing is working the least well. And that's really concerning. So just to summarize, with the bad news is that COVID has spread really rapidly over September. The REACT study estimates that 1 in 200 people in England may currently have it. And this has brought with it a big increase in hospitalizations, and it has now brought with it a recent increase in the number of deaths as well. I've missed out the good news. Right, here we go. The good news is that there are signs that growth is slowing quite a bit, and that's really good. And we've bought ourselves several more weeks of time, which is good, but we are still growing. So ideally, we want to stop growing, have the number of cases decreasing every day. But we have slowed it down. We have bought ourselves more time. Test and trace in England is really worrying. So test results are coming quicker and people are traveling less far. That's good. But capacity has not increased. And we might be skewing the London picture, which I think is bad. Fewer new referred cases are being reached, which is bad. And it's working least well in the area it's most needed. And that's bad. So I think we really do have to kind of work on improving contact tracing. And there's increasing evidence now that super spreading events are really important. So that's where one person manages to infect loads of other people. And a new study published in Nature today shows that firstly, those are incredibly important. So maybe 20% of cases are responsible for 80% of infections, and that they tend to happen outside of the home in kind of social areas like pubs and restaurants. So the way to deal with a super spreading event is really good contact tracing. So it's so important that we get on top of this. So So we are in a situation where we've slowed growth down a lot and bought ourselves time, but we have to use that time for something. Otherwise, why are we doing it, right? We need a strategy. And the government really does need to use this time that we've bought ourselves through everybody changing their behaviours to improve contact tracing, because that's our way out of it. That's how we reverse growth, and that's how we allow those restrictions that they've now put in to be eased off again, so we can start living a more normal life. And that's it.
Thank you very much, Professor Pargle. Now we will move to live questions. And the first question that we've got is from Joe Anderson, the Mayor of Liverpool, where tighter restrictions are being brought in from tomorrow. Joe, what's your question? I'm hoping we've got Joe Anderson here with us.
Sorry, apologies. Earlier this year, we had the national lockdown and we saw the end of the first wave as a result of that. Governments are now making it clear that they will not return to that method of control, instead preferring local measures. So I've got three concerns, and basically the data and science that is available to the national decision-making process is not being shared with local leaders like myself here in Liverpool, which leaves us at a disadvantage. The measures are never going to go far enough because national government doesn't want to provide the support and financial package that was necessary for the national lockdown. And I think national government has also proven incapable, and I think we've just heard that, of communicating the spirit of the restrictions. Instead, they seem to get bogged down in competing detail, and the public has lost their ability and confidence to follow that advice. So what are independent sages' thoughts on what a local response to the virus looks like? And can they, or should they, go further, i.e. the government, I believe they're trying to do this on the cheap. And should government support look at supporting people's livelihoods and businesses in a local furlough way, because we've got local lockdown?
Thank you, Joe. Who would like to take that? I'm imagining that Susan, you might want to speak to that. Can I bring you in at this point? Professor Susan Mickey?
You can. I think there's others on the panel who are more qualified than me to speak on it. But my initial response is that I think absolutely that where there are restrictions, whether they're local or national, in order to A, maintain and improve adherence to the restrictions, and B, look after people's physical and mental health, then there does need to be adequate financial and material support in terms of furloughs. And the issue that you raised about confidence in the government's handling of the pandemic is absolutely key, because without the trust, we're not going to get the degrees of adherence we need. The population has overwhelmingly been adherent to restrictions, but as these become more piecemeal, haphazard, unpredicted, and more extensive, it may be that this will be compromised. So we really do need to look at this.
Thank you very much. Is there anybody else on the panel who would like to answer Joe's question? Professor Gabriel Scally. I think you're on.
Thank you very much. Yeah, it's a good question, Joe. And Independent Sage has been clear from the beginning that we really needed a proper find, test, trace, isolate, and support system. And not just test and trace, it's all the rest that goes around it, as you said, about furlough, but it's also that ability to trace back cases, to find where they got it. And that involves often people on the ground in communities and working with communities to work all that chain of infection out. And it also means being able to help people isolate, say, people who are in houses in multiple occupation with maybe one bathroom and one kitchen for a large number of people who really need to be separated and properly helped to isolate. And local housing departments and local staff are in a better place to help them than anyone in a national call centre. So we have argued for a pivoting of resources and a pivoting of responsibility to local authorities. you've got directors of public health, and you have an excellent director of public health, I know, in Liverpool. And those local teams, local authorities, and the local NHS and GPs and primary care is very important in this. Working with community leaders, with local councillors and faith leaders, that is how we're going to beat this virus. It can't be done by a remote control from private sector call centres in other parts of the country. And I very much hope that you and other local authority leaders will keep up the pressure for local responsibility and local resources, because I don't think you've been given the amount of resource that you need to do a good job, and we absolutely need you to do a good job. Thanks for the question.
Thank you very much, Professor Scally. Does anybody else want to jump in there with an answer to Joe Anderson's question, or should we move on to the next question? I can't see any of you champing at the bit, so I hope that was helpful, Joe. We're now going to take some questions about the current situations in universities, and we have Larissa Kennedy, who is president of the National Union of Students. Larissa, what's your question?
Hi there, thanks for having me. At the National Union of Students, we've been aligned with the recommendations of the Independent Sage Report on universities and called for a digital-first approach to teaching this term, which has regrettably been repeatedly ignored by government and universities. But looking ahead, we remain conscious that for some students who don't have alternative housing, such as care leavers or estranged students, and for those students who don't have a conducive learning environment at home, for example, there will remain a need to access campus. So it'd be helpful to glean a greater understanding of what level of on-campus activity is actually safe, and how crucial is accessible test and trace for both students, but also staff and by extension communities in shaping what is safe.
So I think that's probably a question for Professor Deenan Pillay. Deenan, if you're happy to take that.
Let me start. Larissa, thank you very much for your question. It clearly is it is a really important point that you make, that universities are not homogeneous. All students are not the same, and all student experiences are not the same, but also all campuses are not the same. And so we do, that's one reason why I think we're keen that universities are able to build their own response to the pandemic based around those specifics. And you're right, we've got to weigh up the benefit to students of being, at university against the risks of them of getting COVID. So in a way, I think we just need to make sure there's a stratification. I think it's important in our recommendations that there's proper risk assessments undertaken for all new students and staff coming back at the beginning of a term, so there's an understanding of precisely that risk benefit for each of those students. And finally, that we're very clear that universities need to develop a way of reassuring all their staff and students around testing, about being able to identify infections, but being able to also support those students who do need to isolate, because that itself has consequences as well. Thank you very much. But I'm sure other colleagues have comments as well.
Thank you very much, Dean. And I know that Professor Christina Pargwell would like to comment on that too. Christina.
Yeah, I just wanted to say that I think there's this quite an unhelpful framing that I've seen in the media and also in kind of people discussing it as if somehow students are to blame for spikes in local communities and spikes in universities. Whereas actually what you've done is you've taken people from across the country and put them in halls together in reasonably large groups. If you stuck me in a house with 7 strangers, I'm much more likely to get COVID than I am just where I am now. And I think that has to be acknowledged. All the surveys have shown that younger people are just as worried about COVID as older people, that they're just as likely to follow the guidelines, that they're no more likely to break the rules, really. And we've also seen that during lockdown, that it was younger people who were most affected by loneliness and mental health challenges. So I think we have to acknowledge that students need to be supported at university, and it shouldn't kind of be a kind of a blame game, which I know isn't quite answering the question, but I just thought it was important to say that.
Thank you very much. Does anybody else want to speak to Larissa's question? Yes, Professor Alison Pollock.
Larissa, thanks for your question. I'd just add to what everybody said, the real importance of having good access to primary care support as well. Some universities have really good healthcare centres, health centres, others don't. And I think that's a very important ingredient, is making sure that people with symptoms actually manage to get access to help and diagnostic support, as well as the testing that Dinan's been talking about. And I think it's really important that each university is working well with our local public health department. Many universities are doing that, and that's really important. And of course, the third thing that everybody's talked about is the importance of supporting students who have to go into self-isolation, especially when some students are having to work as well. We need to think about hardship, but also delivering food. In Newcastle University, we've just had a special delivery to the 600 students who are isolating at the moment and living outside of university residences. So these are all the things that we need to be mindful of, and I know you will be especially mindful of. Thank you.
Thank you very much, Alison. And I think that Professor Anthony Costello wanted to answer this question as well. Anthony?
Well, I was just going to ask Larissa, I mean, how well are the universities actually paying attention to proper isolation? I'm a bit worried that if you've got a hall of residence with, 500 students there and a few get tested positive and are just told to stay in their room, that isn't really, in my view, effective isolation. I think you have to have a much better monitoring system. And ideally, I think universities, if they've got a campus, should have a hall of residence where they put infected people and keep them completely separate from others. I don't know what other panelists think, but, Gabriel hinted on it, and I'll come back to it. We are not in this country paying serious attention to proper isolation. And that's shown in the latest figures from Susan Mickey's study and her colleagues, where only 18% of infected people are actually isolating. And that's a disaster, because, we can lock down a country and destroy our economy, or we can lock down partially, like we've got at the moment, which really makes an economy rocky, or we seriously lock down cases and contacts. And that's the most efficient way of getting us all back into a proper economy. And we're not doing that. And if we're not doing that in universities.
Larissa, how do you feel that universities are dealing with isolating cases at the moment?
I mean, yeah, first, thank you so much for all the contributions. And in response to the question, I think it's our worry that, we don't have the plans and the structures in place for students to adequately isolate. We're seeing extraordinarily large social bubbles of students being constructed, and entire halls being told to lock down, which is of course putting several students needlessly at risk. And again, then exacerbating the mental health issues that so many people raised there. So there are a number of issues with the way that this is being handled at the moment. And yeah, it's useful to hear from you all on how that is impacting the kind of spread and things.
Thank you very much for joining us today, Larissa. Now I'd like to bring in Dr. Andrew Lee from the University of Sheffield. Andrew, are you there with your question?
Hi, thank you very much, and good afternoon to the panel. Thank you for accepting my question. I saw your emergency report earlier this week, and I just wanted to raise a concern. You've been calling for increased testing in university settings, including asymptomatic regular testing. As an aspiration, it's the right idea, but I worry about how realistic it is at the present time. We've certainly seen with test and trace, there are real risks and issues around test capacity, resourcing, staffing in the laboratories. And do we risk diverting tests to generally less vulnerable staff and students away from patients, hospital staff, care homes, other vulnerable groups? We know there isn't enough test capacity even for the wider primary and community care, let alone other sectors. And I'm concerned that the recommendations may have potential adverse knock-on consequences of distorting local prioritization of finite test capacity? Thank you.
Such an important question. Thank you very much. Professor Dean Pillay, would you like to start with that one?
Thanks. It's a great question. Very important. And of course, in giving our advice and advice from yourself and others, no one wants to take us away from the core components of the pandemic response. Having said that, at this moment in time, where we've got literally hundreds of thousands of students, of young people moving around the country into universities, there clearly that is a major, potentially a major risk for continued spread. So I don't think we should diminish the potential risk that university openings play in some of the figures that Christina showed earlier. The other observation I'd make is that there's a difference amongst universities, but there are a lot of different sort of approaches that universities are taking to this testing. And what seems to have happened is a generation of new capacity, really, new partnerships between university laboratories, their local NHS structures. Some of them are, in fact, now adding that capacity to the Pillar 2 structures. Some are adding capacity to Pillar 1 structures. So to some extent, I think the ability for universities and at a local level to work with partners to provide capacity that didn't exist before, it just demonstrates that actually with pressure for new demands, particularly, there are local solutions to that. So I think, you make a good point, but I'm also looking with interest at the degree to which actually capacity has increased overall over the last couple of weeks as universities have opened. Thanks, Andrew, for your question.
You're on mute, Alice.
Can I bring in Dr. Alison Pollock to also answer that question? Thank you.
Well, thank you, Andrew, for that question. As you know, any testing strategy is very complex, especially when you're screening asymptomatic healthy people. So it needs a very careful approach, and really we should be doing it, if we are doing it, as part of careful pilots and evaluations, so that we understand the costs and the harms and the benefits. And indeed, some universities are doing that. So it really should have a very strong ethical framework around it and very good information. Because as you know, the PCR test is currently used isn't a test of infectiousness. So that can generate problems too. But also the information that students get is very important. I had a quick look at Cambridge University's testing information, and it's not very good. There's a blurring of whether it's research or whether it's an intervention, and there is no explanation of the tests and what the tests actually mean. So I think all of these things, it's really incumbent on universities to work very closely with public health and possibly the UK National Screening Committee, and to work out very carefully what they're doing, and to, as part of careful pilots and evaluations, so we have really good information at the end of it on the cost, benefits and harms. Because of course, all of this is using a lot of resources, and even if we are building new capacity, it means we may be diverting resources from other really important things that the university could be doing, like the test, trace, isolate and support, isolating and supporting symptomatic people. Thank you.
Thank you very much, Alison. I want to move on to the next question very soon, but I know that Professor Martin McKee would like to comment on this one too.
Yes,
Martin.
Andrew, thank you very much for asking your question. I think we do need to recognise that universities must be a priority with the mixing that we're having. There are innovative ways of doing it, like pooled testing, that I think we can look at. It's been used in the United States. We need to be imaginative there. But I also do need to think I think we need to make a really strong point at the highest level that this is a real risk going forward if we do not invest in this. I'm hearing from colleagues in other universities that it's particularly challenging to get tests, particularly for the medical students, nursing students, and the health professions, that are in clinical settings. And we need clarity on that to begin with. But also, you're right, we need to prioritize this. There are a lot of people in public-facing roles in universities that are offering face-to-face teaching, support staff and others. They are a particular priority in all of this, I would suggest. And just as a general point, as somebody who has shifted from a university that has shifted all of our teaching online, you know, we keep coming back to the point that we should be doing this as much as possible. It's very hard work. It's a bit like trying to be a camera operator, a presenter, and a producer all at the one time. And I think it's about 5 or 6 times more work than giving a conventional lecture. But we recommended from the very beginning that we should minimize the mixing. We weren't listened to, and we can see what's happened.
Thank you very much, Martin. Yeah, I can speak to that hard work. It takes me about 2 days to make one lecture into an online video. I'm going to go next to Ewan Carter, who is a student. So we'd like to know where you're a student, Ewan, and what's your question?
Hi there. Can you hear me?
Yes.
Yeah, okay. So really my question kind of echoes Larissa's earlier one. So I'd like to sort of expand on that if possible. So if I was wondering if Sage's advice on risk assessments for so institutions are required to carry out rigorous risk assessments for their students in respect to COVID. Are they being provided with the necessary information to carry out those risk assessments relating to COVID? And how are they positioned to assess the risk? Yeah, without specialist training, I guess.
Thank you very much, Ewan. I know that Professor Mickey would like to answer that one. Over to you, Susan.
Hello, Ewan. You might like to look at the report that we put out a few weeks ago on returning to workplaces that's on the website, because universities are workplaces. And so we talked there about the importance of assessing risk and for making sure that there are proper acceptable plans in place, but also importantly, for those workplaces to be monitored and visited and inspected. And that requires resources. And for example, the Health and Safety Executive has had their budgets slashed considerably over the last few years. So it's really echoing previous points that we made about distribution of resources to where it's needed and the people who have the expertise and track record of doing this. Yeah, do have a look at the report, because we do go into that in some detail. And the report was supported by both British Society of Occupational Health and also the TUC.
Thank you.
Thank you very much. Anybody else want to jump in on that one? Or are you happy for me to go to the next question? I'm not seeing anybody desperate. So I hope that answered your question, Ewan. I'd like to move on now to Liz Shin. Liz, are you there? What's your question?
Yes, I am. Hello. I was just wondering, we know how much more vulnerable BME adult groups are. Are we seeing the same thing then in younger adults compared to their non-BME peers? That was kind of my question, really.
Who would like to start with that one? Yes, Christina.
I can't answer the question on the age grouping, but the various reports that have come out on hospital admissions in September have shown that COVID hasn't changed in the last 6 months. So the same people that were going to hospital in March are going to hospital now, and for the same reasons. Now, the REACT study showed that BME populations are twice as likely to have COVID right now. So they have been at the front line and are getting it. And we also can see in hospital that if you just look at general admissions and then people in intensive care, again, it's disproportionately BME population. So it does seem as if that is holding true again. And there's another reason why we just really have to try and prevent transmission, because it is affecting certain populations a lot more than others. And just one more thing, in the REACT study showed that people in households of 6 or more people also are more likely to catch COVID. So again, that's people in overcrowded housing, but also multi-generational households, which is more BME populations.
Thank you very much. And for the next question, we'll go to Dr. Jimmy Mushater. Are you there, Jimmy?
Yes, I am. Can you hear me? Well, thank you very much for the time and the expertise in taking my question. And my question is really about vaccines. And the world is awaiting a vaccine on the proviso that once you get a vaccine, the world will return to normality. But my understanding is the FDA have got a bar of 50% efficacy. So a vaccine has to be at least 50% effective. Now, if I do just some simple maths, if 10% of a population are anti-vaxxers or do not get a vaccine for whatever reason, that leaves us 90% of the population that get a vaccine. If it's effective in only half of that 90%, that means only 45% of a population is protected. And then that means 55%, without complicating with T-cell cross-immunity and other things, is still at risk of catching the virus and if tested, of testing positive. Now, if that's the case, how sustainable is this situation where policy is driven by the number of cases, where even after a vaccine, a significant part of the population, when tested, can still turn out positive? And then just quickly, while I'm on the vaccine, are we definitively going to get the immune correlates of protection in humans from the phase 3 studies ongoing? Thank you.
Thank you very much for your question. There are a couple of parts to that, and I wonder if Professor Gabriel Scally would like to comment on the points on the science on the vaccine and immunity.
Do forgive me if I don't get it quite right in answer your question. I missed some bits of it. But the vaccine is very important, and vaccines do vary in terms of their efficacy. Some vaccination can be extraordinarily protective, others less so. But we're hopeful, of course, that we get a really effective vaccine, and at their best, they can have a very, very low level of people who don't develop an immune response following the vaccine. And that's what we hope will happen in this one. But in some diseases, for example, tuberculosis, the vaccination, the BCG, is a useful adjunct to other therapies. With regard to COVID-19, we don't have any preventive therapies, and we don't have very many therapies that are good in terms of clinical care of the patients yet. So in order to deal with vaccine, we're reliant either on our preventive measures that we have been discussing about test, trace, isolation, and so on, and the social restriction measures, or the appearance of a vaccine. For me, the main determining factors of the success of the vaccine will be our ability to get that vaccine, when it appears, to the population. I think we've had some really interesting experience in the country now with the flu vaccination that's going on at the moment with through general practice. And what I've seen of that is that they have changed their style of delivery of that really quite substantially, and making use of large spaces and getting the throughput of people. It's an enormous logistic exercise, even to transfer that vaccine around the country in terms of making sure the cold chain is in place. So it is a complex arrangement, but there is no reason why if we have a vaccine and we can get it delivered to the significant majority of the population, that it won't have a tremendous effect to protect us all.
Thank you very much. Professor Cole-Friston, I think you'd be able to comment on this as well.
Yes, so excellent question. So I'm going to answer this from the point of view of the quantitative modelling, and I'm going to give a slightly reassuring answer. I get the impression that people are very worried that, one, the vaccine won't be very efficient, and even if it is, it cannot be produced in sufficient quantities, and even if it is produced, then not everybody will take it. I think a key aspect that we've learned about the epidemic so far is the importance of heterogeneity at 3 levels in terms of exposure, susceptibility, and transmission. Those kinds of heterogeneity mean that we may need a very much lower herd immunity threshold that can be induced through vaccination than you would otherwise expect. So if you don't factor in the heterogeneity, then you would have to render a much greater proportion of the population immune through vaccination than otherwise. But we've heard about things like super spreading events. There's a lot of interest now technically in over-dispersion, the K statistic. All of these things speak to a heterogeneity of transmission. They're important because what it means is it is possible that a very, very low herd immunity threshold can be attained with a reasonable degree of social distancing, indeed back to normal. So I'm just providing a perspective that possibly paints a rosier picture than one might imagine, in virtue of just acknowledging the many factors that are in play and all interacting, and crucially, this heterogeneity.
Thank you very much. And we need a rosy picture from time to time, Carl. Thank you. We've got a question now from Dr. Nizreen Alwan via Twitter, and she can't join us right now, so I'm going to read out her question. She's an associate professor at the University of Southampton and a consultant in public health, so this comes from a position of some expertise. Why isn't Independent SAGE recommending universal face coverings in secondary schools and colleges in all shared indoor spaces, including lessons? Who would like to speak to that one? I'm looking for hands up. Right, there is a hand up, so I don't need to pick on people right now. Alison.
Yes, that's a very difficult question to answer, but I'll have a go. I think, again, this is about masks being a very complex public health intervention as well. And there's a lot of uncertainty in the science. But one of the real issues, of course, is how you handle your mask, putting it on and off, and the need for hand hygiene, and how difficult that is in a secondary school setting where children are putting on the mask to go into corridors and then taking them off again in the classroom. And we have to remember that there's quite a lot of evidence, I think, on the importance of visual and oral communication. So this will really impair some students' ability to communicate, to hear, etc., if they're wearing a mask all the time. But anyway, I've had a go. There's still a lot of uncertainty. Again, if you were going to do this intervention, you should be doing it as part of careful controlled studies and not underestimating the importance of all the other measures, which is getting the school right, the social distancing right, the hand washing, but also creating smaller class bubbles as they do in Denmark. But I do know that in some countries, of course, they are using masks in secondary schools, and we've made a reference to that.
Thank you very much. It is of concern, of course, in this country where we've got no reduction in class sizes at all since the beginning of term in most schools. And I know that Professor Susan Mickey, you'd like to comment on that question as well.
Yes, thank you. Of course, we're surrounded by uncertainty. The virus is uncertain, the transmission is uncertain, the way it plays out is uncertain. But meanwhile, we are being asked policy questions such as this. And I think this is an issue that we may come back to. We're a small group of people with a long list of requests and ideas for reports. I think we have about 6 on the stacks at the moment. But there's, in a situation where we've got the R level above 1, this means exponential rising of the transmission rates. It does mean that choices will have to be made as to how we keep the most important parts of society going. And I think that people do value school children being able to attend school very highly. And so therefore we need to look at all the mitigating strategies that there could be to put in place. And not all school ages are the same, both in terms of infectivity, but also in terms of what's appropriate. And certainly I've had many teachers raise this question about shouldn't at least the 16 to 18-year-olds be wearing masks? they're in an enclosed indoor space. Why is it that 1 year older in universities they may be asked to, but not at school? And also the other issue for this age group is whether some of that teaching or more of that teaching or all of that teaching could also be put online. So I think these are things that we need to think about depending on how the picture goes. But I think if the situation continues to deteriorate, then there will be some hard choices to be made. And I think this may be easily one of the mitigating measures that would be warranted. And I think we're very happy to have a look at that.
I do want to squeeze a couple more questions in, but I know that Anthony, you're very keen to answer this one as well. So Professor Anthony Costello.
Thanks, Nisreen. I think probably the reason we haven't is that there are different opinions on the panel. I completely agree with you, actually. And the reason is not based on randomized trials. It's based on the fact that Taiwan has seen 0.3 deaths per million, China 3 deaths per million, Korea 8 deaths per million, and we're at 660 deaths per million. And they have done 2 things spectacularly well. One is everybody wears a mask almost everywhere, and certainly secondary school students would all wear them without question. And the second thing that they do is that they follow the guidelines from WHO on isolation. So Taiwan requisitioned 7,000 hotel rooms. We should have requisitioned 20,000 hotel rooms to cover out so that people who needed to isolate went there. We should have paid people properly to isolate. We didn't pay them anything for the first 3 months. I mean, we've now paying them a smaller amount, but there's no focus on this is a respiratory virus. You need masks on. It's not going to be perfect. These are adolescents, for God's sake. But, you know, I think we should be doing it. If I was headmaster of a school, I would insist on it. And I think you're right, Nisreen, but it is controversial and it's difficult to find hard evidence. Christina might come out with a different opinion.
But I'm not going to let Christina in just yet. She might have to wait a little minute, if that's all right, Christina. Sorry about that. I want to get on with another couple of questions, and one of them is about schools as well. So perhaps we can fold in some of our responses to the previous question to that. It is from Dr. Sheetal Arjun Odedra. Dr. Sheetal.
Hi, thank you. I just firstly wanted to thank you all very much for considering my question. I once was a virologist and now training to become a secondary school science teacher. And I'm here basically because I feel quite sad and frustrated about the plight of schools, in that 6% of schools in England are now impacted by COVID in some way, and 16% of secondary schools particularly. And with the lack of accessibility to testing and the fact that we're sort of in peak cold season, and potentially approaching flu season, my worry is that we're going to end up with lots of teachers as well as students in isolation absolutely unnecessarily. And we also see that attendance rates are dropping already. And I guess my fear is that we end up having schools having to close down simply by default because teachers and students are in isolation. And so thinking in terms of line of a strategy or solution, we've touched upon this already a little bit, which was really interesting. What are your thoughts on routine pooled PCR screening of entire school bubbles as a surveillance strategy, maybe weekly, once every fortnightly, but also thinking about potentially saliva-based testing as a way to try and overcome issues with parental consent? I know that Cambridge and Nottingham University are already using this protocol, as well as maybe other universities too. But I just think it could really keep teachers in school, students in school, and schools open. So yeah, what do the Independent Sage think about this as a solution for schools? Thank you.
Thank you for a fantastic question. Please keep your answers brief now. We're running up against time. I'd like to come to you, Professor Christina Pargle.
Okay, I'll leave the question on pool testing to Dinan, but one of the things that is, I think, really bad for schools is that at the moment, if you have symptoms and you get a test and you test negative, you can come out of isolation. But if you're a contact, there's no way for you to come out of isolation early. You have to wait the 14 days. And in schools, it seems that a lot of the infections that are being picked up are actually in teachers and not in children. And obviously, 1 or 2 teachers being off has a much bigger impact than 1 or 2 children being off. And so that is a problem. And I do think whether there's a role in schools for doing some repeat testing of contacts, so that after maybe 7 days, if they've tested negative twice, they can then go back early or something along those lines. But I mean, I'm not a testing expert, so I'll hand over to Deenan.
Deenan, you've got the floor very quickly.
Well, first of all, Sheetal, if I heard you right, you were a virologist. I'm sorry for that, but you're doing a much better, more impactful job being a teacher. So congratulations for that shift. I mean, again, there's been 1 or 2 people who vary in their views within Independent Sage. My view is that, you know, we need to maintain the confidence of parents and teachers and school children to continue at school. And there are a lot of innovative ways to undertake testing which can reassure, as well as, of course, identify outbreaks, which of course are a risk not necessarily to the children, but actually coming home to extended families and teachers and so forth. So I agree with you. Actually, I think, you know, there is an opportunity to bring some new technologies, whether it's pooling. There's also an interesting, some universities in the US are testing sewage outlets as an early marker. There are a whole range of things, and we should really actively do that in order with the goal to keep schools open. Thanks.
Thank you very much. We've got another question from John Muir. As quickly as you can, please, John.
Hello, can you hear me? Yeah, thanks very much for taking my question. My question briefly is related to flu vaccination. I'm getting my flu vaccination today. I'm not considered to be in an at-risk group. I'm in my 40s. I will therefore pay for it. That does make me wonder, considering the pressure that flu could put on the testing system, and I also understand it's co-infection with flu is a risk factor for severe COVID. Has there been enough emphasis on getting the flu vaccine out universally as an integral part of the winter strategy? The second question I've got is my children obviously get the flu vaccine. Their children are super spreaders of flu. They get a live attenuated flu vaccine in their nose. I noticed that I'm getting inactivated flu. It did occur to me, is it worth people getting live attenuated flu vaccine, unless of course they're immunocompromised? I did try to, but it's not possible for people of my age. I mean, I read about the polio vaccine, which is live attenuated, possibly being used, you know, because there's this phenomenon of cross immunity. I just wondered whether it might be worthwhile or whether there's a downside that means that's not worth doing. So really, those are two parts of my question. Has there been enough focus in my kind of age group to take pressure off the testing system, and is it worth getting live attenuated flu vaccine? Thank you.
Right, one person from Independent Sage is going to get the opportunity to answer this question. Is there anybody who's desperate to answer it? Otherwise, I'm going to pick on Anthony. Anthony.
No, I'm not the right person. I think it's Gabriel or Martin who are proper public health people. All I would say is I'm actually the wrong side of 65, and I have been called to, but there's quite a queue to get the vaccine, and I haven't got mine yet. And my wife, who's 5 years younger than me, still can't get a vaccine, even though she has some risk factors now as a result of COVID. So it doesn't seem from personal experience that it's as efficient as it might be. But on the question of inactivated versus live attenuated, I'm sure Martin would have a better answer than me.
Well, I was going to say that Deenan actually is probably the person to answer that one. Sorry, we're bouncing it around. I think you're right. We haven't had enough emphasis on the flu vaccination. The one thing that may be quite hopeful is that if we look at what's happened in the Southern Hemisphere, all of the measures that have been taken to limit the spread of COVID seem to have had really quite a marked impact on the spread of influenza. So fingers crossed. The only difficulty is that, of course, in the Southern Hemisphere, they've been in general quite good at adhering to all the rules, and they may not have some of the challenges that we've had. So I think we may be very lucky, we may get away with it, but I think you raise a very good point. But on the attenuated and the virus, I think I would leave that to Deanan.
Deanan.
Well, thank you for the question. Just on one of the really interesting things about the live attenuated vaccine, flu vaccine in the nose, is that it of course elicits immune responses which are both specific to flu, but also provide a more antiviral immune milieu. And there's a lot of interest whether, in fact, that could be used as boosting early immune responses that will prevent actually from COVID. Now, the degree to which that can be used over a season compared to immediately before COVID exposure is unclear, but there are experiments, clinical trials going on of that. So it's an interesting, tangential point from what you've just from the question. But thanks. And clearly it is important that as many people get flu vaccine as can get it this season. There's no doubt about that. Thank you.
Thank you very much.
Thank you. So we have time for just one final question now from Stephen Oakman. Stephen.
Hi, can you hear me? Good afternoon. My question is, please, when Independent Sage was formed, you obviously had a very important message to get out there. And at this point in the process, what I'm keen to understand is whether, from the panel, their point of view as to whether Independent Sage and Sage are in unison. That's the question, please.
I think probably the best person to answer that is Sir David King. And Sir David, if you would like to answer that question and then wrap up for today, please.
Well, thank you very much, Alison. Thank you for the question, Steve. I think the answer to the question is that there is some agreement between the experts on this group and the the experts on SAGE. But frankly, the overriding position of Independent Sage continues to be somewhat different in that we are, I think it's fair to say, much more prepared to be critical of the way the government is handling this. Now, if I could just seg into what I want to say anyway at the end of this, it is that if you look at what we have emphasized from the beginning and what we feel SAGE has not emphasized, it is the importance of find, test, trace, and isolate. The whole test and trace system is the way in which infectious disease epidemics are brought under control, whether it's in the human population or in the livestock population. And yet, in mid-March, the government abandoned the test and trace system in this country. And of course, the upshot of that was that we sat around, if you like, twiddling our thumbs in government for too long while the epidemic was taking off at an exponential rate. It was expanding, quadrupling every week. Every single week's delay caused a massive increase in the level of infectivity in the country. And so here we are, 8 months later, and we still don't have an operative test and trace system. And if anyone asks, why is Independent Sage still existing? I would just point to this one fact. And why is it not functional? I think it's precisely because, or we think it's precisely because the government abandoned the normal public health process, which is a local authority-based process. It's paced through GPs. It's GPs who should be reporting on the disease level in their amongst their constituents. And they abandoned that. And eventually when they understood, and this wasn't until May, that they needed a test and trace system, they brought in 2 private sector companies that had no health care experience. And so what we saw was a long period where the disease was running rampant until we went into total lockdown. Of course, that was successful. But then we started talking about undoing the lockdown too early. And around June the 1st, that nice decreased rate of infectivity in the country started expanding again. Now it kept it kept going down, but the rate of decrease was diminishing. And so we were saying we must try and get as close to net zero COVID in the country before we can actually release the lockdown process. And the reason for that is if the level of infectivity in the country is high, as we open pubs and so on, we're going to see it spread again. Inevitably, that has happened. So I think it's fair to say that Independent Sage has been putting a very clear message across. And even today, we're saying it's not too late. You still haven't got an operative test and trace system. Give it up. You can write off the private sector companies that you've given the job to because they've failed. Time to move over to the public sector.
Thank you very much, Sir David. I'm going to bring this meeting to a close for today. We've heard some very positive news today that people are changing their behaviour and that this is seeming to have an effect. We've also got good reason to believe that vaccines will be effective even if we have relatively low herd immunity. There are concerns about how well universities are supporting students and helping them particularly to isolate, and enduring concerns from Independent Sage about the whole test, trace and isolate system. Thank you to all of our panel. Thank you for your attention today if you've been watching. All the reports that have been published by Independent Sage are available on the website with details of the whole team that you've seen today. Do follow Independent Sage on Twitter if you're not already following us. We'll be back same time, same place next Friday. Have a good weekend. Stay safe. Keep well.
Bye.